looks like it's about a 7% chance of this happening over a 4-year time period. But when it came down to the composite endpoint of major adverse cardiovascular events or MACE, if you have all these risk factors on testosterone or off testosterone, it looks like it's about a 7% chance of this happening over a 4-year time period.
Yeah, so that sounds relatively high, but in this specific patient population, it is expected. But of note, there was no significant difference. So when it comes to removing the label specifically for ASCVD events, heart attacks, and strokes, I think that's reasonable. And this could be the study that pushes that over the edge.
Yeah, and important to note that these patients, the LDL level was around 80. They were also on antiplatelet therapies. So it's not like they just put them on testosterone with no other medical interventions. They're on the standard of care for these chronic conditions that they had.
Shouldn't they stop their toxic statins when they start testosterone?
I suppose we would have seen I actually think we've seen a very different outcome if everyone quit their statins when they started the testosterone.
I wish we could have seen that. But yeah, this was conducted largely at academic centers like Cleveland Clinic that are practicing evidence-based medicine, tracking ApoBs and things like that to prevent ASCVD progression. And of note, people know that I call testosterone and androgens in general inverse statins because they activate or induce the same enzyme that statins inhibit, which is inactivate. So they do the opposite thing. So I think it is particularly reasonable that they continue that therapy.
Yeah, and one of the unfortunate things is we weren't able to see how the cholesterol levels changed in response to the therapy. It just wasn't published in the supplementary data.
Yep.
We did see blood pressure changes. That was something that was logged at each of these appointments. But presumably these patients were getting their lipid checks and other blood markers, A1Cs and things like that throughout the visits as well. It just wasn't published for us to review. But this first graph here, the one that we've been talking about that shows the MACE endpoint, also shows us our first signal of some potential harm associated with the testosterone. And that relates to venous thromboembolic events and then pulmonary embolism. The hazard ratios for those for VTE, 1.46. And then the hazard ratio for pulmonary embolism, it's not calculated there, but it would be 2. That's fairly easy.
Yep.
Exactly double the events in the testosterone arm.
No huge difference in DVT, which is blood clots in the leg. Pulmonary embolism is blood clot in the lung. 12 versus 24, that's twice as many. Should I immediately take all of my patients off testosterone as I'm your TRT clinic doc? Should I take all of them off? That's twice as many.
No, but it's a discussion to have when we talk about risks and benefits. And when you're talking about any medication, if the risks and the benefits, make sense for that particular patient based on their values, risk tolerance, and the improvement in quality of life, because that's really the takeaway from this study. Testosterone is largely a quality of life medication. In most cases, it's prescribed. There can be cases made for things like bone mineral density, sarcopenia, or someone who very early on, or they have a hypogonadism that's secondary to another cause, perhaps testicular cancer. Then they truly do need a replacement therapy for long-term health issues that could develop. But most of the testosterone being prescribed now is a quality of life drug, just being honest.
Yeah, and this is another reason why if you look in a vacuum at each specialist, if you look at a specialist that's only looking at, for example, testosterone's effect on the genitourinary system, like urologist, then they might not see all the benefits across other organ systems. You can't be a hormone specialist without being well-versed in all organ systems. You could say the same for a psychiatrist. A lot of psychiatrists are familiar with the benefits that testosterone has on many psychiatric conditions, even depression. Yeah. And a lot of specialists in many different locations are either hyper aware of the risks, like cardiologists, or hyper aware of the benefits, like hormone optimization clinics, I suppose. So just finding that balance and trying to address everything possible is important. It does take time. It's probably not 1 5-minute consult per year. This is probably longitudinal care over time, getting to know your doctor or your nurse practitioner, just like they're your friend, asking questions directly to them rather than to someone who is not a physician or nurse practitioner. And yes, it requires talking about things like platelets and maybe even thromboxane, mechanism of action of how AFib happens, how clots happen. It is reassuring how many patients and also friends have messaged both of us since this study came out, because a lot of them think they think, did we account for risk of blood clot in the lung? Did we account for risk of AFib? Yes. That's why we discussed this. That's why I take a low dose Eliquis when I fly in an airplane for a long period of time, et cetera.
Yeah, it's something that we like to really take a comprehensive look at, because it seems like patients either get a like absolutely yes, you need this, or a like absolutely no, you should never take this, it's poison. And having a more long form discussion of those benefits and risks is really valuable. And I think to your point about taking every single one of your patients off of testosterone, let's say,